Welcome to this Clinical Explainer. Today, we're pulling back the curtain on one of the toughest challenges you will ever face in the consulting room. I want you to step into the role of my supervisee for a bit. We're going to adopt the rigorous lens of a case supervision to really dissect the complex phenomenology and treatment of a condition that regularly burns out even the most seasoned practitioners, narcissistic personality disorder. If you have ever felt completely depleted, bored out of your mind, or outright enraged after a 50-minute hour with a patient, you are absolutely in the right place. Here is our roadmap for today's session. We'll start by recognizing the clinical presentation, then break down the oblivious versus hypervigilant subtypes. After that, we'll dive into the psychodynamic formulations of Kohut and Kernberg, figure out how to actually select a treatment technique, talk about surviving the countertransference crucible, and wrap up with how NPD looks across the life cycle. All right, let's jump in. Section 1, Recognizing the Clinical Presentation. Let's talk about what actually walks into your office. Now, when someone with severe narcissistic pathology sits on your couch, your first job as a clinician is separating the cultural noise from true clinical dysfunction. We live in an era fueled by the instant gratification of social media, that whole me generation vibe. So you're probably highly familiar with the standard DSM-5 diagnostic criteria. We're talking about the grandiose, boastful, entitled individual who requires excessive admiration and basically treats everyone else like disposable objects. This criteria paint a very specific picture, the loud, arrogant person who demands the spotlight. But listen, as a clinician, you have to know that the DSM-5 has a massive blind spot here. It's severely limited because it completely misses the quietly grandiose patient. The vulnerable, shy individual who actively runs from the spotlight due to an extreme, exquisite sensitivity to slights. If you're only relying on the DSM-5 playbook, you are going to misdiagnose a vast number of patients suffering from profound narcissistic pathology. Which brings us to Section 2, the phenomenological divide between the oblivious and hypervigilant subtypes. Let's see how this actually behaves in the room. To really conceptualize these patients, we have to rely on a clinical continuum bordered by two starkly different subtypes. The behavioral split in the clinic is wild. The oblivious patient is totally self-absorbed. It's like they have a sender, but absolutely no receiver. They will talk at you, not to you, completely blind to your reactions. Conversely, the hypervigilant patient tracks your every single move. If you shift in your chair or clear your throat, boom, they view it as a sign of crushing boredom. There's actually a classic case in the literature where a therapist simply plucked a dead leaf off an office plant during session, and the patient felt so humiliated they instantly demanded a new therapist, literally over a leaf. So the crucial point is understanding why they behave this way. Both subtypes are desperately trying to maintain their incredibly fragile self-esteem, but their defense mechanisms are polar opposites. The oblivious narcissist throws up a heavy shield of grandiosity. They insulate themselves by just completely screening out the responses of others. The hypervigilant narcissist, however, is terrified of being seen. Their core inner world is drowning in a deep sense of inherent defect and shame, so they actively avoid vulnerable situations to prevent feeling humiliatingly exposed. All right, Section 3, Psychodynamic Formulation. Let's look inside the patient's mind through the lens of two titans of psychoanalysis, Heinz Kohut and Otto Kernberg. To successfully treat these patients, you must understand the architecture of their pathology. Kohut looks at the narcissist and essentially sees a child stuck in an adult's body. He believed their normal self was developmentally arrested because their parents failed to empathically validate their natural childhood need to show off and be admired. Kernberg strongly disagrees. He views the patient as operating at a borderline level, using a highly pathological, grandiose self. To Kernberg, this structure is a rigid fusion of the ideal and real self, built specifically as a defense against needing anyone. It is a strict pseudo-self-sufficiency. And this brilliantly illustrates the divide when it comes to how aggression shows up in the consulting room. Kohut is much more charitable regarding your patient's rage. He frames it as secondary, an entirely understandable narcissistic rage reacting to an empathic failure on your part, just like they experienced with their parents. Kernberg, however, says, watch out. He warns us to look for primary, destructive aggression fueled by chronic, intense envy. In Kernberg's view, the patient is tormented by feeling inferior, and they must actively devalue you and your help to avoid recognizing that you have something good that they desperately need. Moving to Section 4, Selecting a Treatment Technique. Knowing the theory is one thing, but how do we actually intervene?
These differing theories dictate vastly different approaches to what you should actually say to the person sitting across from you. Kohut advises you to use empathy as your absolute cornerstone. You must accept the patient's material at face value to avoid repeating the parent's failures. If the patient idealizes you, accept it as a normal developmental need for psychic structure. Kernberg insists on the exact opposite. He argues that if you only focus on the positive, you actually increase the patient's fear of their own rage. So he says you must confront and interpret their idealization as a defense, and systematically examine their envy and greed. Otherwise, that envy will prevent them from ever truly accepting your help.
But let's be real, purist approaches rarely work for every single patient. You treat patients, not theories. Building a therapeutic alliance here is a formidable challenge because these individuals absolutely dread the humiliating exposure of their imperfections. So, practically speaking, establishing the alliance requires this careful, step-by-step approach. First, you have to identify goals that you both actually agree on. Second, you must openly acknowledge that reaching these goals will expose their vulnerabilities. Only after this alliance is totally secure can you move to step 3, safely confronting them with their own contributions to their interpersonal difficulties.
Which brings us to Section 5, Surviving the Countertransference Crucible. This is all about managing your own reactions. And honestly, this is where your mettle as a clinician is truly tested.
I want you to be brutally honest with yourself for a moment. Why do you dread your sessions with this patient? Trust me, it is entirely normal for junior and senior therapists alike to find themselves staring at the clock, feeling a profound sense of uselessness, or dreading the arrival of a narcissistic individual. If you cannot acknowledge and harness your own narcissistic needs as a therapist, you are going to act them out in the treatment. Let's look at a clinical vignette from the source text. With an oblivious patient like Mr. FF, you are going to experience a very specific, agonizing countertransference: crushing boredom. Mr. FF was completely unaware that his therapist had just been on a 3-week vacation. When the therapist pointed this out, Mr. FF basically told him, "I'm not paying you to talk about you," completely invalidating the therapist's autonomy. You are assigned this satellite existence, used merely as a nodding sounding board, while your existence as a separate person is utterly denied. On the flip side, look at the experience of treating a borderline-level narcissist like Miss Gigi. When her doctor thoughtfully refused to prescribe her barbiturates, she launched into a severe verbal barrage, calling him a complete joke and declaring him beneath contempt. When working with a patient like this, you will face severe devaluation that engenders intense countertransference hatred and feelings of utter impotence. You are going to feel an overwhelming, entirely human urge to retaliate or make vengeful management decisions. So how do we survive this crucible? Managing your internal experience is the absolute core of the psychotherapeutic work. When you feel bored, reframe it clinically. Recognize it as the patient projecting their own emptiness and denying your presence. When treating a hypervigilant patient, notice how their constant monitoring makes you feel controlled and coerced into sitting perfectly still. You have to contain their projected abuse, whether it's searing contempt or controlling anxiety, and you have to do it without sadistically retaliating or withdrawing. And finally, beware of the high-functioning, charming narcissist. It is way too easy to fall into a comfortable mutual admiration society where you just enjoy the show, completely failing to do the actual therapeutic work. Finally, we arrive at Section 6, NPD across the life cycle. We need to look at the tragedy of aging. Here is the harsh reality. The narcissistic defenses that worked so beautifully in their youth inevitably begin to fail. As youth, beauty, and early career success start to fade, these patients face an unavoidable crisis. Because of their chronic envy, they are often robbed of the vicarious pleasures of midlife, like enjoying the success of younger colleagues or their own children. So instead of gracefully maturing, they often engage in frantic, ill-advised affairs or dramatic religious conversions just to avoid mourning. Eventually, they will arrive in your office deeply lonely, feeling unloved, and profoundly embittered. Which brings us to the tragic, isolated fate perfectly summarized by this historical warning from Benjamin Franklin. He who loves himself will have no rivals. As a clinician, this is exactly what's at stake in your work. The ultimate question I leave you with is this: can you hone your clinical skills enough to withstand the countertransference crucible? Can you navigate the grandiosity and the profound shame and help these patients build even a small, fragile bridge to genuine empathy and connection before the clock runs out on their lives? Thank you for joining me for this explainer, and I'll see you in the next supervision.